Chapter 22, the third chapter for this week, the last for this week, and next week we're going to get into chapter 23, 24, the neurologic disorders, Parkinson's and Alzheimer's, and the drugs for neuromuscular disorders. So this chapter is on anticonvulsants. I'm not sure how much you've studied on anticonvulsants at this point, but I'm going to try to help you so these drugs make sense. So, what is epilepsy? This picture was pretty good to help you figure out. Your text talks about it. This picture shows you the synapses. It's an abnormal electrical discharge from cerebral neurons. Characteristics are loss of conscious or convulsive movements. Causes, a lot of them, most of them are unknown. There may be secondary causes such as trauma, anoxia, that's without oxygen, infection, stroke, maybe an isolated seizure due to a fever, an electrolyte or acid-base imbalance. Types of seizures. This I thought would help because different drugs deal with different kinds of seizures. You have your generalized seizure, which includes all of these. If you think about this, atonic is without tone when they go limp. Tonic is the entire body is tense. Tonic-clonic is where they go back and forth from contracted sharp tone to no tone. Myoclonic is specific to the muscles, or it might be like a psychomotor type of thing. Absence seizures, sometimes referred to as petit mal, and they're a brief loss of consciousness, 10 seconds or less, and those usually occur in children. You have your partial seizures. The seizure activity originates in just one part of the brain. And then I just threw this slide in to just show you the progression we've had and see over the last, not now, I guess there's nothing real recent, but after 2000 there was quite a few different medications that came out to help manage seizure disorders. This is another picture. I have a slide after this too to help you understand the different places where the drugs are working in the brain. This makes you more specific. They either suppress the sodium influx. These drugs here, they suppress the calcium influx. They block that calcium channel. Or they enhance or promote the GABA release. Gabapentin is the only one in here that just promotes the release. The others enhance the action of the GABA, or GABA. Okay, so some of the classes. Hyding-toins, a very common class. The most prevalent that you will see is phenytoin. Some people will know it as Dilantin, but generic is phenytoin, and when you get the drug level, it's a phenytoin level. I know I've learned in the past trying to look on the lab thing for a Dilantin level. It's not going to be that. It's going to be your chemical or generic name phenytoin. If you notice, the level is between 10 and 20. That's a narrow therapeutic index. It works by suppressing the sodium influx. It has a very narrow therapeutic index. It is greatly protein bound. I threw this picture in to help you. I think some are still trying to grasp the protein bound issue. So if the drug is protein bound, it gets there and it gets released a little at a time as it's released from the protein. If there's very little protein, like in an elderly person, somebody who's got a lot of muscle wasting, or somebody that's on another drug that is highly protein bound, there's just so many protein receptors. So a lot of the drug, if it can't connect and bind to the protein, it is free out here. So if a drug is very protein bound and they either have a low serum albumin, some other risk that makes their protein low, like a liver disease, alcoholic, or on another drug that is protein bound, you have a high risk of having excess free of that drug and being out of that therapeutic range, especially when it's a narrow therapeutic range such as phenytoin of 10 or 20, and being toxic or greater than 20. So with this, you'd want to greatly teach on toxic symptoms and have close monitoring of that phenytoin level. I put here so you can see it comes in oral and injectable forms. It is tetragenic in pregnancy, high risk, although sometimes you don't have a choice, but it's very high risk in pregnancy. Lots of food and drug interactions. In your text, chart 22.1, phenytoin drug lab food interactions, look over that because there are a lot of them. So kind of be familiar with that. Some of the interactions, well, you can look at a lot of, in this class, not just phenytoin, hydantoins have interactions. So almost all in this class have an interaction, and they have interactions with other anticonvulsants. Main drug interactions are with cimetidine, which, cimetidine, INH, sulfonamides. You should also see a trend with cimetidine and sulfonamides. That's a lot of drug interactions, especially with these seizure meds. The drug, it can decrease the effect of folic acid, antacids, calcium, sulforaphate, which is for GI, antineoplastics, antipsychotics, and decreases the effect of some herbs of primrose and ginkgo. So if they have to take it during pregnancy and it's blocking the folic acid, I'll cover that at the end of this lecture because that is important. It also decreases the effects of anticoagulants. So if somebody is on warfarin, it's decreasing that effect rather than potentially like many do. So they may need a higher dose of warfarin if they're also on a hydantoin such as phenytoin for seizures. Decreases effect of oral contraceptives. So somebody that is not wanting to get pregnant may need to use a different contraceptive method. Decreases antihistamines, the effects of dopamine and theophylline. Theophylline we covered in the respiratory. And the ginkgo goes both ways. The phenytoin decreases effects of the ginkgo, and the ginkgo also decreases the effects of the phenytoin or hydantoins. I threw this in just because there are so many adverse effects with phenytoin. This picture is hyperplasia of the gums. It's called gingival hyperplasia. They can also have nystagmus, which is where the eye does the twitch. Headaches, diplopia, which is double vision, dizziness, slurred speech, decreased coordination, alopecia, which is hair loss, thrombocytopenia, where here megaplastic anemia due to folate deficiency, and thrombocytopenia is all of the clotting platelet factors are decreased, so you'd see a platelet count probably down 120, 100, very decreased. You do want to know what your normal platelet levels should be to understand when it's decreased from like a thrombocytopenia. Hyperglycemia and glycosuria, which leads to, due to a decrease in insulin secretion. So using these to figure out some of your nursing interventions and patient teaching, they have a nursing process in your text starting on, 308, ends on 311. Nope, actually it goes further. It ends on around 312. Definitely look over that because phenytoin is very commonly used. And it has lots of teaching, lots of things to watch for. If you notice on patient teaching, they have a little electric bolt next to multiple factors. I'm just going to cover a few. If they're on a suspension, it is an oral form, but it's a liquid suspension. You want to shake the suspension well for 5 minutes. Definitely watching the serum drug levels because it has a narrow therapeutic range. Warn female patients about taking oral contraceptives or use an additional contraceptive, which I covered. Avoid certain herbs, alcohol, other central nervous depressants. Warn them not to discontinue it abruptly. No anticonvulsant should be discontinued abruptly. Need frequent oral hygiene, dental checkups. Use a soft toothbrush to prevent gum irritation and bleeding. Diabetic patients need to monitor their glucose level closely. They need to take the drug at the same time every day. If you look on your table 22.2, go down to your hiding toys. You see the pregnancy category D. Let's see. Wear medical alert identification. Watch for pinkish, red, or brown urine because of kidneys with this being excreted. Okay, I think that's pretty much, and you can look in your text. Report sore throat, bruising, nosebleeds because of the blood dyscrasias and the thrombocytopenia potential. Oh, I forgot I had this in here. So here is your nursing process, more things to report, to look for, and I pretty much covered those, and your text does a good job. So next on to barbiturates, which enhance the activity of the GABA by depressing conduction in the brainstem and cortex. Phenobarb is one of the barbiturates that you will see. I always remember what class it is because the barbitol in it, I think of barbiturates when I see barbitol. That's my trick to remembering it. It does have a therapeutic range. It's not quite as narrow as phenytoin, but there is a range. Again, it is category D, and it can be in injectable IV or oral tablets. In your table 22.2, it tells you that it's used for grand mal and petit mal or absence seizures. Sometimes it's used in combination with others. It too is a pregnancy category D. The generic of phenobarb is what you'll see used most. It's long acting. High doses for older adults or children may cause confusion, depression, irritability. Adverse effects include suicidal ideation. Long-term use with high doses cause physical dependence. And you notice the IV or PO doses for adult and children according to their weight. If it's a suspension, again, you want to shake it well for 5 minutes. I gave you a therapeutic range, risk of sedation, and building a tolerance. Discontinuation of phenobarbital should be gradual to avoid recurrence of seizures. Your text only does the nursing process whole thing for phenytoin, but you can pretty much, I'm trying to give you keys on looking at this table to be familiar. Next class, succinimides, which you will find on the very bottom of table 22.2 on page 308 on the first page of it. It decreases calcium influx. The one that you will see is ethosuximide, and again, If you look in here, succinimide, and it has succinimide in the name, so you know it is a succinimide. Therapeutic range is pretty broad, 40 to 100. I put this picture to help you remember what kind of seizures it is used for, which are the absence or petit mal seizure. It can also be used for myoclonic seizures. I didn't put that picture, but this explains what an absent seizure is, which it's most commonly used for. Gastric irritation is very common, so take it with food. It's actually is a pregnancy category C rather than a D like others. It's in adults and children. Some adverse effects with these are blood dyscrasias, renal and liver impairment, and systemic lupus erythematosus. Benzodiazepines. There's quite a few benzodiazepines. They are the second group listed on table 22.2. Clonazepam, clorazepate, diazepam, lorazepam. I'm saying the names to help you see the azepam in the name of benzodiazepines. So the diazepine, anazepam in the names to help you key in. These are three of the classes for you to be familiar with. I mean, not the classes, the benzodiazepines. The diazepam is the only one of these three that can be given intravenously, which we'll see later at the end when we talk about status epilepticus, which is an emergency. These two are oral. Diazepam is oral and IV. So clonazepam is effective in controlling petit mal or absent seizures. Unfortunately, an intolerance can occur within 6 months after starting the therapy, and often will have to change to something else. Clorazepate dipotassium is administered just as an adjunct to other things for treating partial seizures. Diazepam is primarily prescribed for treating acute status epilepticus. You won't see somebody on this routinely for a seizure disorder. To get a response to stop seizure activity, diazepam has to be given intravenously for seizure management, and is used, I said, in status epilepticus. It has a very short-term effect, so it needs to be given during or immediately after administering. Another anticonvulsant has to be given immediately or while you're administering the intravenous diazepam. You have to give it IV slowly because of respiratory depression and drop in blood pressure or hypotension. The dose has to be repeated in 10 minutes to try to get the level up. And it is a pregnancy category D. I can't say this word, I apologize. Imidazolpidine. I am sorry. I know carbamazepine. Now I'm going to get stuck on that. I know this as Tegretol. So carbamazepine, again, that's one that you're going to be doing therapeutic drug levels. If they're on Tegretol, you're only looking for Tegretol. It's carbamazepine is the drug level that you're looking for on your labs. If you notice, it also has a narrow therapeutic index of just 5 to 12. It is used for partial seizures. I gave you a picture here to help you with that. It's also very effective in treating refractory seizures, seizures that are not responding to other anticonvulsants. It can be used for grand mal in addition to partial seizures or seizures that are a combination of several different types. This class is 1, 2, 3, the fourth one down near the bottom of table 22.2 on the first page of it. You'll see it's only given in oral form. It is one drug that is also used with bipolar, psychiatric disorder, a manic disorder. It can be used in trigeminal neuralgia. It's used in alcohol withdrawals, but we're focusing on the seizure use here. I put this grapefruit on here because it has an interaction with grapefruit juice, and it can lead to a toxicity with this narrow therapeutic index that it has. Valproate. It has a very wide range of a therapeutic index, but you will be doing levels on valproate or valproic acid. Valproic acid is what you will see, commonly ordered in the form of Depakote. Again, when somebody's on Depakote and they need drug level, you're looking for valproic acid, so you need to know this name, valproic acid. It is used in petit mal, grand mal, and mixed type seizures. It cannot be used in children under the age of 2. Use with caution. You see the little liver here to help you remember. It can cause hepatotoxicity, so caution in patients with liver disorders because hepatotoxicity is one of the possible adverse reactions. So when you are on valproic acid or Depakote, they need to be monitoring the liver enzymes. It's also used for other things like manic depression, manic episodes of bipolar disorder, and migraines. Anticonvulsants in pregnancy. Your text has a section on page 308. It talks about this, and so it's one of those risk and benefits. If somebody has seizures, they can cause hypoxia, which leads to compromising fetal survival and reducing fetal growth rate. So you have to control the seizures. And almost every one of these, as you notice, they're category D, so they're tetragenic, which can cause deformities. And then on top of it, a woman with epilepsy that gets pregnant increases a 25% chance of having more seizures during that pregnancy. Another, it inhibits, some of these may inhibit vitamin K absorption or function, inhibiting the function of vitamin K. Vitamin K is needed to control bleeding. Vitamin K is what you give to reverse the effects of warfarin when it gets too high and the clotting factors are off. So it may inhibit vitamin K, and it can contribute to, if a woman is pregnant and having to take an anticonvulsant, it can contribute to hemorrhaging in the infant shortly after birth. So this is one of the ones where they're watching and giving a vitamin K right after birth. And that sort of stuff is covered more when you get into OB next year. It also can increase the loss of folic acid, and you know folic acid and neural tube defects such as spina bifida and anencephaly, being born without a brain, which is not compatible with life. So it's just a hard thing there. So any female childbearing age with a seizure disorder really needs some major counseling on reproduction. You have to monitor the serum phenytoin levels in pregnancy very, very closely because seizures tend to be more frequent due to increased metabolic rates. So any of them that you have a narrow therapeutic index, such as phenytoin, you're going to watch because they're using it faster and may need a higher dose during pregnancy, even if there's all this other risk. Anticonvulsants and febrile seizures. I just listed this for you because it's self-explanatory. Seizures associated with fever usually occur in children between the ages of 3 months and 5 years. That does not mean they have epilepsy. Approximately 2.5% of children develop epilepsy if they've had one or more febrile seizures, and from what I've seen, it's usually more than one febrile seizure, meaning they had some other risk in there for this unknown causes of epilepsy. This prophylactic anticonvulsant treatment, such as phenobarbital or diazepam, may be indicated for high-risk patients. I've not seen that used, but I have not worked in a primarily pediatric population. I haven't worked in an acute setting, so if there's other multiple risk factors, I would assume things like certain overdoses, family history, a history of several febrile seizures, maybe a head injury, put them at risk, and they'd want to do all anticonvulsants. They usually say 3 to 5 years. Most providers will say 5 years, neurologists, of seizure-free before they consider going off. Just because they go on an anticonvulsant doesn't mean they're on it for life. So usually the threshold is 5 years of seizure-free to consider weaning, tapering off an anticonvulsant to see if it's still necessary. And there are people that are successful on getting off of it if the cause of those seizures, the epilepsy, is completely unknown. And again, valproic acid, not to children under the age of 2 years old because of the damage to the liver. We are just about done. Status epilepticus. In your text, it has just this one little paragraph at the very end of your chapter. Status epilepticus, I gave this picture to help you. It's abnormal electrical impulses that continues for at least 30 minutes. There are different definitions out there. Some say 60 minutes. If it's continuous, it does unrelenting, it is a medical emergency. Your text gives you the rundown of administering diazepam IV, followed by lorazepam. The next is IV administration of phenytoin. And if the seizures continue, doing midazolam, which is Versed, which was briefly mentioned in the previous chapter, and propofol, which was also mentioned in the previous chapter, midazolam being used for like a conscious sedation, and propofol, which is more significant, administered usually by anesthesia, but as a registered nurse in critical care areas, you may be administering propofol drips. So I put the actual pediatric lifesaver guideline on here for status epilepticus. Anytime, yes, you read it in the text or somebody says it to you or you found it on a site, make sure it is a reliable guideline. So I put this in there to help you understanding with status epilepticus where these guidelines from the textbook came from, even though this is in the pediatric. The doses may be different in an adult, but it is the same steps exactly as laid out in your textbook. And that actually is the end of this unit, and the first 3 chapters are covered. Next week's lectures will be on chapter 23 and 24, neurological and neuromuscular disorders, and that is the end of this presentation. Thank you.